Hello, my name is Phil Pereira, and I'm the Emergency Ultrasound Coordinator at the New York Presbyterian Hospital in New York City, and welcome to Sound Bites. Today we're going to go over the Tale of Two Pregnancies, Part 2. So today's case involves a 29-year-old female who has a G3-P2 with a last menstrual period of approximately 8 weeks prior. Now her history was most significant for the fact that she was having lower abdominal pain, but no vaginal bleeding. She had performed a positive home pregnancy test, but had not seen an OBGYN for this pregnancy. So based on the fact that ectopic pregnancy was in this differential diagnosis, we quickly moved her into the OBGYN exam room and decided to take a look with ultrasound. So let's review the transvaginal ultrasound images that we obtained from the case. Here's the ultrasound image that we obtained from our patient. This is a long axis configuration, so we see the fundus of the uterus located to the left and the cervix to the right. Note the thickened endometrial stripe coming down the midline of the uterus. It's that white area in the interior of the uterus. And note also the pelvic cul-de-sac, the potential space where fluid can accumulate posterior to the uterus. Notice here the absence of any significant dark or anechoic fluid collections within the pelvic cul-de-sac. Notice also the absence of a definitive intrauterine pregnancy, as we talked about earlier in Module 1, that would be signified by a gestational sac with a yolk sac or a fetal pole. Next, we'll reorient the probe into the short axis configuration to re-examine the uterus in a second orientation. Here we have the probe in the short axis with the probe marker over towards the right side. Thus, we're cutting the uterus in cross-section. Here we see the thickened endometrial stripe in the midline of the uterus and the pelvic cul-de-sac posteriorly. Notice again the absence of an intrauterine pregnancy and also the absence of any significant free fluid within the pelvic cul-de-sac. So in this case, the transvaginal ultrasound failed to show evidence of an intrauterine pregnancy. Now I should tell you in this case that we actually had the luxury of knowing the beta-HCG as it was sent prior by nursing staff, and it came back at approximately 30,000. So given the very high beta-HCG without findings of an intrauterine pregnancy, this case was very suspicious for an ectopic pregnancy. So let's review some of the facts associated with an ectopic pregnancy so that we can have a little bit more knowledge in terms of knowing what we were actually looking for. Here are some important facts about ectopic pregnancy. Ectopic pregnancies constitute about 2% of all total pregnancies, but they're more commonly seen in women with tubal ligation who are using intrauterine devices for contraception, or those who have a history of sexually transmitted diseases, especially pelvic inflammatory disease with scarring of the tubes. Ectopic pregnancy is also common in women who are using fertility agents. So as a golden rule, we want to consider ectopic pregnancy in all women with abdominal pain and/or vaginal bleeding and a positive pregnancy test until ruled out by ultrasound evaluation. A question that often arises in a discussion of ectopic pregnancy is what is the risk of a heterotopic pregnancy, where I have one intrauterine pregnancy and a second embryo growing in an ectopic location. Well, in 1948, in the general population, the risk of heterotopic pregnancy was calculated at about 1 in 30,000 pregnancies. However, more recent data show an increased risk of heterotopic pregnancy, mainly because of the increasing amount of in vitro fertilization in our population. In the general population, the risk is now thought to be as high as 1 to 4,000 to 1 to 8,000, but in the in vitro fertilization population, it can be as high as 1 in 100 to 1 in 500. In this patient population, it's always important to get an OBGYN consult, even if you see an intrauterine pregnancy, as the risk of heterotopic pregnancy is relatively high. Also, another important concept is the relation of the serum beta-HCG levels to an ectopic pregnancy. A very important point here is that ectopic pregnancies secrete beta-HCG at atypical levels in contrast to the steady levels secreted by an intrauterine pregnancy. Ectopics have been seen with low beta-HCG levels as low as less than 100 milli-international units. Ectopics, on the other end, have been seen with very high beta-HCG levels, higher than 30,000 milli-international units. Therefore, the defining concept here is one cannot use a single serum beta-HCG level to exclude an ectopic pregnancy. Here's an illustration going over a quick review of the OBGYN anatomy. Here we see the uterus to the left and the adnexa to the right. Recall the areas of the uterus as seen to the left, the lower cervix, the intermediate body, and the upper fundal region. Now we define an intrauterine pregnancy as being located within the fundal region of the uterus. We see the area where the fallopian tube enters into the uterus, which is defined as the interstitial region in a normal uterus and a corneal area in a bicornuate uterus. We also see the areas of the fallopian tube, the proximal isthmus, the intermediate ampullary region, which is where most ectopics are actually located, and the distal infundibular region. We can also see the broad ligament that encases the fallopian tube and the ovary. Notice the ovary, which is adjacent to the infundibular region of the fallopian tube. Here's an illustration showing the location of ectopic pregnancies. Normal uterus to the left, bicornuate uterus to the right. Recall that an intrauterine pregnancy is defined as fundal in location, but interestingly enough, we can have variants of ectopic pregnancy that are located even within the uterus. And one that we can see is the interstitial location in the normal uterus to the left, or a corneal pregnancy in the bicornuate uterus to the right. This is defined as an implantation near the area where the fallopian tube enters into the uterus. We can also see, however, that an implantation low in the area of the cervix is also going to be defined as an ectopic pregnancy. Now, most ectopic pregnancies will be located within the fallopian tube, and the majority of these will be in the ampullary region. We can see that 80% of ectopics are located there, right within the ampullary region of the fallopian tube. But we can also have proximal ectopic pregnancies located within the isthmal region or distal within the infundibular region. Notice also that there can be uncommon ectopics that implant within the ovary, within the peritoneal cavity, or even within the general abdominal cavity. And these can be very difficult to pick up on ultrasound and commonly grow to a late stage before being diagnosed. As we now have a better understanding of where to look for ectopic pregnancies anatomically in the female pelvis, let's go over a strategy that we can use when employing bedside ultrasound to look for ectopic pregnancies. First of all, we want to evaluate the uterus thoroughly for an intrauterine pregnancy. Second, if an intrauterine pregnancy is seen, we're then going to evaluate the myometrial rim surrounding the gestational sac, known as the endomyometrial mantle. And this is the distance between the outer part of the gestational sac and the rim of the uterus. We want to assure that the mantle is greater than 8 millimeters to effectively rule out an interstitial or corneal ectopic pregnancy. Third, if no intrauterine pregnancy is seen, we'll evaluate the pelvis and cul-de-sac area for free fluid that may be suggestive of a ruptured ectopic pregnancy. We should include the transabdominal views on this examination to look into the pelvis as well as the right upper quadrant for fluid. Fourth, if no intrauterine pregnancy is seen, we can also evaluate the adnexa and ovaries for masses suspicious of ectopic pregnancy. Here's a nice table from a very important article by Dr. Mateer in the Annals of Emergency Medicine 1996 going over the ultrasound findings in ectopic pregnancy. We see the ultrasound findings to the left and the likelihood of ectopic to the right. We'll begin with an empty uterus and small amount of pelvic fluid, which has a 52% likelihood for ectopic. Notice that a complex pelvic mass increases the likelihood to 75% for ectopic. As you start to see a moderate to large amount of pelvic fluid, the likelihood goes up to 86%. And visualization of a tubal ring, also known as the bagel sign, has a likelihood of 95%. Now, if a pelvic mass is seen with free fluid, the likelihood is as high as 97%. I find very interesting here is that the presence of hepatorenal free fluid or a positive trauma fast exam in the right upper quadrant has a likelihood of 100% for ectopic pregnancy. Now, if you visualize the ectopic, of course, that will be 100% likelihood for ectopic. So here are some of the findings that we'll go through as we talk further about the ultrasound sonographic findings in ectopic pregnancy. Let's begin by looking at some video clips from patients with ectopic pregnancy by looking at this one. This was a patient who presented with a positive urine pregnancy test, vaginal bleeding, and a large amount of lower abdominal pain. We're looking at a transvaginal long axis view here, and we see the uterus in the middle of the image. We fail to appreciate an intrauterine pregnancy. But what we see here is a large amount of free fluid, that dark or anechoic fluid, posterior to the uterus in the pelvic cul-de-sac and coming around the uterus anteriorly. Notice the presence of echogenic blood clots also seen anterior to the uterus. These findings of no intrauterine pregnancy with a large amount of free fluid, very suspicious for ectopic pregnancy. Here's another case. Again, we're looking in a transvaginal long axis orientation, and we see the uterus. Notice again, we fail to appreciate the presence of an intrauterine pregnancy here, and we see a large amount of free fluid surrounding the uterus, and notice the clotted blood that has more of an echogenic appearance, as in contrast to the darker or anechoic appearance of the free fluid as seen at the upper part of the uterus. So, a large amount of free fluid and blood clot without a visualized intrauterine pregnancy, very suspicious again for ectopic pregnancy. So, in the last case, as we did not visualize an intrauterine pregnancy and we saw a lot of free fluid, we decided to scan out towards the adnexa. Here, we have a positive finding. We see free fluid towards the right and echogenic blood clot towards the left, and inferiorly, we see the bagel sign or the tubal ring of an ectopic pregnancy. Notice that the bagel sign has an echogenic or lighter type circle appearance with a hole in the middle. And this is suggestive of a fallopian tube ectopic pregnancy. Here's two still images showing the bagel sign, which is the thickened fallopian tube of an ectopic pregnancy. Notice with the bagel sign that we have a brighter or hyperechoic circular type appearance, and this results from thickening of the fallopian tube due to growth during the ectopic pregnancy. Towards the right, we see the bagel sign in relation to the uterus, and notice that it's adjacent but outside the uterus. So this is a classic finding with a fallopian tube ectopic pregnancy and can be looked for if no intrauterine pregnancy is seen on bedside ultrasound. These nice images were submitted by Drs. Taylor and Dr. Sacco. As the ovary is commonly confused with a bagel, let's go over two video clips showing the differences between the two structures. Towards the left we see the bagel sign, and towards the right we see an ovary with a cyst. Let's look closer at the bagel here towards the left. What we see here is the hyperechoic, brighter appearance of the bagel. Notice this small lumen, the dark area in the middle, that's all that's left of the inner part of the fallopian tube. Notice that this has a very different appearance than the ovary as seen over towards the right. Notice that the ovary is a larger structure and has multiple outer peripheral follicular cysts. Notice that this ovary contains a central corpus luteal cyst, which is commonly seen in pregnancy on one of the ovaries. But as we scan through it, we see a very different appearance of the ovary versus the bagel. The ovary can almost be described as a chocolate chip cookie due to all the follicular cysts. However, the bagel only has that single hole in the middle, kind of the inner hole of the donut, if you will, indicating the fallopian tube. Here's video from another patient who is pregnant and bleeding, and we note here the long axis scan through the uterus. Now at first glance it was difficult to discern where were the margins of the uterus and what was going on in the cul-de-sac, but as I closely inspected this view, I could see that the uterus was located anteriorly, and you can see the endometrial stripe, and that it was definitely a secondary structure, a complex pelvic mass that was located within the pelvic cul-de-sac. Very suspicious for ectopic pregnancy, and with OBGYN consultation this actually turned out to be a positive ectopic. Here's another ectopic pregnancy, and I'm scanning out from the midline uterus, as seen there, out towards the right adnexa. And notice there what we see is another complex pelvic mass out towards the right adnexa. Next we're going to still that image down, and it almost looks like an egg-like type appearance of a structure inferiorly within the adnexal mass. Very suspicious again for an ectopic pregnancy. So our next move was to do Doppler sonography of the adnexal mass, and what we see here is a classic ring of fire. Notice that the ring of fire surrounds the ectopic as seen inferior here to the ovary. Why is that, you may ask? Well, ectopic pregnancies draw a huge amount of vascularity towards them, and what we're seeing here is the increased ingrowth of blood vessels surrounding the ectopic, showing it to be different from the ovary, which is located just above it. Here's another version of an ectopic pregnancy. Again, we're scanning from the midline uterus, and we fail to appreciate any intrauterine pregnancy. And as we scan out towards the left adnexa, we see a positive finding right there. And we notice there, we see a thickened fallopian tube with contents inside. So go ahead and still down that image. And what we see here is a thickened fallopian tube, and inside the thickened fallopian tube we can make out the Cheerio or the yolk sac, and we can actually see the fetal pole. Now as I scan through that area with video, we could see the flicker of a heartbeat indicating a live ampullary ectopic pregnancy. So another flavor of ectopic pregnancy where we can actually make the diagnosis by visualizing the ectopic pregnancy directly within the fallopian tube. Here's a definitive ectopic pregnancy in a patient who presented to the emergency department. What we see here is the uterus towards the left and towards the midline, and out towards the right adnexa we can see a thickened fallopian tube, and inside the fallopian tube we can make out a fetal pole with a heartbeat, indicating a live ampullary ectopic pregnancy. Interestingly enough, as we measured the crown rump length of this ectopic, it turned out to be 8 weeks gestation. This is interesting as most ectopics in the tubes will rupture at about the 6-week mark. Unfortunately, this patient was not a candidate for methotrexate therapy as the presence of a heartbeat in an ectopic pregnancy is a high likelihood risk that methotrexate therapy will fail. So this patient needed to have surgical excision of the ectopic pregnancy. Here's a great video clip submitted by my colleague Dr. Veronica Hlibchuk showing a live ectopic pregnancy adjacent to an empty uterus. We see the uterus towards the right, and we see the definitive ectopic pregnancy towards the left. We see the thickened fallopian tube, and inside the tube we can make out a yolk sac and a fetal pole with a heartbeat. Now notice that on first glance, one might misidentify the ectopic pregnancy as being within the uterus as being an intrauterine pregnancy. But close attention to the anatomical orientations of the uterus versus the location of the ectopic will help you to sort that out. So this was a definitive ectopic pregnancy needing surgical management. As we discussed earlier, there are variants of ectopic pregnancies that are located within the uterus. The classic one is a corneal ectopic pregnancy within a bicornuate uterus. Now, bicornuate uterus, as shown here, results from a congenital developmental abnormality with division of the superior uterine fundus by a septum. Here we see the septum coming down the midline and dividing the bicornuate uterus into 2 limbs. Within the rightward limb, we see a corneal ectopic pregnancy located. Unfortunately, there's not enough room here to accommodate full growth of a pregnancy, and these can rupture, albeit at a later gestational age than a normal ampullary ectopic pregnancy, but can cause a great deal of hemorrhage as a result of vascularity of the uterus. Here's a bicornuate uterus in short axis configuration, marker dot over towards the right. As I scan up the limbs of the bicornuate uterus, I see 2 limbs of endometrium indicating the 2 corneal limbs. But when I look in the leftward limb, I see the presence of a corneal ectopic pregnancy. And here we'll go ahead and still that down. And what we can see there is that the corneal ectopic pregnancy is located off to the side and has a very thin endomyometrial mantle. It's right up against the wall of the uterus, indicative of a corneal ectopic pregnancy. We can see there the yolk sac and the fetal pole within the gestational sac. Now we're going to measure the endomyometrial mantle, which is where the calipers are placed from the inner part of the gestational sac to the outer part of the uterus. Now we should have at least 8 millimeters of endomyometrial mantle for a normal pregnancy. Notice here the mantle is very thin at 3 millimeters, again correlating with a corneal ectopic pregnancy. Here we're looking at a cervical ectopic pregnancy, or an ectopic pregnancy that's implanted low within the cervical region of the uterus. Again, this will be an ectopic pregnancy as it's not within the fundal location that we defined an intrauterine pregnancy to be located within. Here we see the cervix to the right, the fundus to the left. We're looking at a transvaginal long axis scan here, and notice we see the ectopic pregnancy burrowed in within the upper lip of the cervix there. And we can see a gestational sac with a round yolk sac or Cheerio within the gestational sac, indicating the ectopic pregnancy located within the cervix of this patient. Next, we're going to use the zoom function on the ultrasound machine to get a better look at the cervical ectopic pregnancy. Here we can see the cervix in more detail, and note that the ectopic pregnancy is well seen here with the outer gestational sac and the inner yolk sac or Cheerio within the upper lip of the cervix. Again, this would be an aberrant or cervical ectopic pregnancy managed the same way as other ectopic pregnancies in ladies. So now that we've looked at a bunch of ectopic pregnancies on video, let's go through a strategy for the evaluation of ectopic pregnancy in the emergency department. In women presenting to the ED with a positive urine pregnancy test and vaginal bleeding, abdominal pain, hypotension, syncope, or risk factors for ectopic, you should proceed directly to bedside ultrasound without waiting for the serum beta-HCG. If a definitive intrauterine pregnancy and no risk factors for ectopic, such as in vitro fertilization, you can discharge the patient with close OB follow-up. However, if there's no definitive IUP is seen, you must order the serum beta-HCG and get an official ultrasound and/or an OB/GYN consultation. Here's a strategy that's commonly used for an indeterminate scan where no intrauterine pregnancy is seen on bedside sonography. If the patient is hemodynamically unstable, and especially if there's a lot of free fluid within the pelvis or abdomen, OB will generally take the patient to the operating room. However, if the patient is hemodynamically stable, the patient will often be discharged with close OB follow-up in 2 days for a repeat serum beta-HCG and a repeat ultrasound. In a normal pregnancy, the serum beta-HCG will double in 2 days in the majority of cases. This is in contrast to ectopic pregnancies, where the beta-HCG will have less of a rise in the majority of patients. Unfortunately, this rule is not 100%, and there are cases where in upwards of 25% of ectopics, a doubling of the beta can occur. So that's why you must repeat the ultrasound again in 2 days as well. This information comes from a great article by Dr. Dart, Annals of Emergency Medicine, 1999. So now that we've discussed some important facts and figures about ectopic pregnancy, let's describe what we're actually looking for on the transvaginal sonogram. So we must consider ectopic pregnancy, as we talked about earlier, when we fail to see an intrauterine pregnancy with a relatively elevated beta-HCG. Now, if we look at the adnexa, we may be lucky enough to actually see the ectopic pregnancy as visualized by a yolk sac or fetal pole within the tubal ring. But many times we're not going to see this, and we're going to see findings that are suggestive of ectopic pregnancy, such as free fluid within the pelvic cul-de-sac or within the abdomen. So given our patient's very high beta-HCG and the lack of an intrauterine pregnancy, we decided to actually examine her tubes for the presence of ectopic pregnancy. So let's go over the actual transvaginal ultrasound images of the tube that we obtained in this case. So here's the sonographic findings to wrap up the conclusion of the case. Here we're scanning out from the midline uterus, as shown there, out towards the left adnexa. Notice in the left adnexa a positive finding. And we see here a thickened fallopian tube or a bagel. And let's look inside the bagel. And what we see there is the presence of a fetal pole. So we'll go ahead and still that down, and we see again the uterus to the left or towards the midline, the thickened fallopian tube out towards the left adnexal region, and within the thickened fallopian tube, the presence of a fetal pole, making the diagnosis of a ampullary ectopic pregnancy. So our next move was to call OBGYN stat for a consultation. So in conclusion, the final diagnosis in this case was ectopic pregnancy. And what was interesting about the case was that we were actually able to visualize the ectopic on closer inspection of the adnexa. So I think that's an advanced maneuver, and one that you can employ when you become more and more adept at transvaginal ultrasound. But let's remember the basics, that if you don't see the intrauterine pregnancy within the uterus and the beta-HCG is relatively elevated, you must get OBGYN involved in the case. So I hope this case has been helpful for you, and I think it really again shows the benefit of employing emergency bedside ultrasound, especially in the pregnant patient. So have a great day and take care.